My name is Nancy Gildersleeve, and I am the Executive Director of DISRP Operations and the Fulton Population Health Network here at AHI. I'd like to all welcome you to the Community-Based Organization Breakout Session, a glimpse into CBO MCO partnership. It is my pleasure to introduce our panelists today. Louisa Marra. Louisa is the Associate Executive Director of Homeless Services at St. Kathryn Center for Children and has over 25 years of experience working, planning, directing, and supervising staff providing youth services to youth, adults, and families experiencing homelessness. She has extensive training in evidence-based practices, which include critical time intervention, motivational interviewing, and SOAR. She currently oversees Marra Homeless Family Project, Project Host, permanent supportive housing for families and individuals in Albany and Columbia County, and has served as the project director for SAMHSA Treatment for Homeless Programs, providing street outreach and engagement services in Albany County. She also serves on several committees in Albany and Columbia counties. Welcome, Louisa. Kathy Leyden. Kathy serves as the Director of Community Engagement at CDPHP. She has an extensive background working with at-risk population, including individuals and families impacted by homelessness and poverty. In her current role, Kathy develops partnerships with community-based organizations to support population health initiatives. She coordinates internal and external resources to address social determinants of health and supports the organizations in maintaining a strong presence in the community. Kathy is a board member at the Albany County Coalition on Homelessness, as well as CARES, a regional nonprofit organization that empowers communities to end homelessness through community planning, program data, supportive housing, and awareness building. Welcome, Kathy. Charlene Schlude. Charlene is currently the Director of Care Coordination at the Capital District Physician Health Plan, responsible for oversight of case management and readmission avoidance programs. She has over 21 years experience in the Department of Member Health at CDPHP and has been influential in development and expansion of its complex case management programs. Previously, she enjoyed a 14-year career at Albany Med in the Pediatric Intensive Care Unit and post-anesthesia recovery room. Charlene is a board member and past chairman of the Healthy Capital District Initiative, which is a nonprofit board dedicated to improving public health and access to care for uninsured populations in the Capital District. Welcome, Charlene. Thank you very much.
Thank you, Nancy. Can everybody hear me okay? Mm-hmm. Great. So as Nancy mentioned, my name is Kathy Leyden. I work for CDPHP. I'd like to thank all three PPS for the invitation for us to come in today and tell you about our story of partnership between CDPHP and St. Kathryn's. We're definitely excited to be here today and happy to help rescue you from your post-lunch food coma. So hopefully we keep it interesting for you. Just a couple of housekeeping items. Kind of our presentation style is we're going to toggle back and forth. Charlene and I kind of have a Laverne and Shirley vibe going. We've been working together a long time, and with Louisa in the mix, we often joke that the three of us can share a brain. We finish each other's sentences. So we'll try to keep it interesting for you. We'll be going back and forth. We're going to be covering a few different things for you today. We're going to first give you a little bit of background information about each of our organizations. Then we're going to give you some background info about Project Host, which was an MRT-funded initiative that was really the inspiration for CDPHP and St. Kathryn's housing collaboration. Then we're going to talk to you about the relationship building and contracting phase that we went through and are still going through, as well as the service delivery model for the program itself, and then we'll close with measurement and sustainability. We ask if you have any questions, just jot them down. We'll have plenty of time for Q&A at the end. So with that being said, I'm going to hand it over to Lisa to get started.
Good afternoon. Can you hear me?
Yes.
Okay. One of the things that was not on my bio, I don't really do these things, so please bear with me, and I'm glad I have the support of my team to kind of end my sentences when I need them or kick me to shut up. So I do get better as I move along, but you know, this is something I don't usually do. So I wanted to talk about St. Kathryn Center for Children, and you know, we're located in Albany, New York, and we have been around for probably 125 years, you know, from being an orphanage to now evolving and serving individuals. This is a new program for us because we are often known as, you know, the agency that takes care of children. But, you know, we have a comprehensive range of human services, and we offer hope. I mean, I think that's the scope of our work. We foster growth, and we improve the lives of children, families, and individuals. We are publicly funded, and we offer services which include treatment and education for the community, and our target is the most at-risk children, families, and individuals. Yeah, she's got to do the clicker until we move it along. So our community-based comprehensive homeless services for families and adults, they include what, you know, they were in my bio, a new, you know, so we have an MRT program, we have a family homeless shelter, and we also have HUD vouchers, HUD-funded vouchers for singles and for families. And something that's unique of being in Albany, we also serve Columbia County, which is rural, and that's a new experience for us, and we've been in Columbia County for a couple of years now. We also have foster care services. We have a day treatment program for children aged 5 to 13 years old, and we have prevention services for families referred through family court. Mayor-like Homeless Family Program, there's a typo there. We're funded through Office of Temporary Disability Assistance. We've been operating since 1988, and it's an emergency shelter for families. We provide shelter for 24 families, but they're all individualized apartments, and we have case management services, and we focus, our goal is to focus on what community resources are available, so when we are moving them back into the community, they're well connected, and we reconnect. We do supported employment, and we also have on-site childcare, which includes transportation, recreation, after-school program, and on-site groups for the mothers and fathers that we serve. And now,
great. Well, see, she's a pro. She didn't give herself enough credit.
I gotta go back.
So, again, I'm Charlene Schlude, and I'm really excited to talk about this because partnerships of this nature are not easy to get off the ground, and we've really been very fortunate. We say all the time, something's got to happen here because it's going really well. So I'm going to start with my little CDPHP infomercial because you aren't allowed to go on without doing that. We are in 26 counties, and we're basically a physician-driven, not-for-profit, mission-driven health plan. And we're very proud that we're in 26 counties and the type of work that we serve. And we have 365,000 members, so we're not the largest plan in the area, but we feel like we really get very in touch with our members. We're really proud of that. We don't want to be too big. We want to be able to always be that. But we have good provider relationships as well, because across the country with our national network, we have more than 825,000. So that's really what we want to do, is be very close in touch with our membership. And one little accolade that we want to give ourselves, sorry about that. We're very proud of some of our awards and recognitions, and I'll just go over one, which is for our Medicaid plan, for NCQA, which is our accreditation around quality. We were ranked 4.5 out of 5, which makes us among one of the best health plans in the state, so we're really proud of that. So now we'll go on basically just to talk about population health a little bit, because that was really a big driver for this collaboration. And I don't think anyone here would disagree that population health is really the big focus today with any health-related organization. So we thought that it was important to really partner with some of our CBOs, specifically St. Kathryn's, because we really needed to address the social determinants of health, which we know make such a difference in people's lives and can make it so much harder for them to access their healthcare services. One of the key social determinants of health, as we know, is homelessness. That makes someone so much more at risk, and their health conditions will be worsened by being homeless. We know that, we've seen the research on that, and so it was important for us to really make this type of a partnership so that we could all work together on some of the really important challenges that the people in our community are facing. And we're seeing a rising number of homeless individuals in our health plan. I don't have the exact number today. We do keep registries, but it's underreported because we don't have the access to everyone until we come across an individual who needs our supports, and then we track that. But what we do know is that when Medicaid redesign occurred and they began to bring in some of the fee-for-service included populations, homeless individuals were part of the populations that the state is having MCOs manage. And they felt we could do a good job, and we're really pleased to be able to do that with the supports of services like St. Catherine's. On this slide, we just have this little schematic just to show, in our population health model, we like to look at all of the different populations that we serve. You know, everyone from our healthy individuals to our emerging risk to our chronic conditions, and then our really complex individuals. So when we look at our homeless populations, they almost always fall into the chronic and complex. They don't ever really fall very far to the left. And with that said, when we can get someone housed, we can oftentimes left shift them back a bit. And that's really our goal and our mission, to improve the quality of their life. So I kind of like this little example to show. So our multidisciplinary team, so we're going to hear a lot about how we started to work with St. Catherine's through the partnership that Kathy helped us arrange. But prior to that, and today as well, we have a very multidisciplinary care team at CDPHP, and it includes a variety of staff. And basically, we recognize that 20% of a person's risk in their health is going to be basically from the care they receive, but a lot of it is based on their genetics, their social determinants of health, and we know that if we don't address those things, we're not going to be able to move their health along. So our care teams, they provide a lot of face-to-face interaction. We started to going out to the community and seeing people in health clinics. We see them in homeless shelters. We are in our doctor's offices when need be. We go to hospitals. And we were able to really identify people through the emergency room and hospitals and community settings. This face-to-face engagement, we feel, is most important because that's how we're going to build relationships with people. And so our care team includes registered nurses with a varied medical backgrounds. We do have licensed behavioral health social workers on our team that have all worked in some sort of a behavioral health setting and bring a lot to the table there. We have medical social workers, and they can really help with a lot of the different programs that are out in the community that they can help get them linked to. We also have a asthma educator on our team, as well as certified diabetes educator and a nutritionist. So we try to have a full complement of clinical teams that can go out and meet with our members along with St. Catherine's, which you'll hear about. And our teams use HCSNY. We had a great presentation today about HCSNY and the value that it brings, and we can say that we use that very frequently to gain information when we're working with our teams. I'll pass it on to Louisa.
So I'm going to talk about how it all began. And, you know, we at St. Catherine's serving, you know, homeless, we applied for an RFP through New York State Department of Health, the MRT program, the Medicaid redesign team. So our proposal that we wanted, what we wanted funding was to meet people where they were at. We wanted to be out on the street, and that's what we did. You know, we really didn't think we had a chance at this, but what we were finding with serving our population, if they were eligible for HUD-funded apartments, it was a long process, and if they weren't engaging in any treatment, the documentation to prove their disability was very difficult. This group also, although they could access shelter, would not. And it's for many reasons. We have great shelters in Albany, but you know, the number of people in one room, where they were at in their own recovery, really prevented them from accessing shelter. So this is who we really wanted to target. So we were really fortunate to be able to just walk out our door and walk the streets. So we were going to parks, we were going under bridges, and you know, through that experience, we, let me back up a little bit. So we were funded. Let's start with that. And they were going to, we started out as a pilot project with 32 units, serving Albany and Rensselaer County, and we, you know, we could choose who went into the apartments, and we were looking for our most vulnerable in our community, the ones that were really scoring high. So when you look at the definition of, you know, MRT, and, you know, they're looking at 2 visits in a year, we were coming across people that were having 2 visits in the morning. And that's really who we felt we were there to serve. So our primary focus, of course, we needed to decrease Medicaid, you know, ER utilization, and improve health outcomes. So we started going out and just talking to people and to, you know, our clients and asking them, you know, what they wanted. And so we wanted to be client-driven. So it was more about how can we help you, because today they may not want housing, they may want to eat, and then tomorrow they may just give us a little bit more information as we continue to engage them. And I'll talk a little bit about the evidence-based practices that we do use later on. So we started going to shelters, and then we started engaging the police. And the police started referring people to us. And from that, they referred us to Albany County Mental Health. And they said, you know, there's this committee in Albany, operated by Albany County Mental Health, and you need to be at that table. Because that's where they talk about this group. The community comes together once a month. They talk about what clients think they need, or what, you know, and what services were available. So we started attending the FCC meetings, which is
Patient Service Coordinating Committee.
Yeah, I never could get that right. We call it PSCC. And you know, so monthly we would go there and they would share clients. And it was kind of tricky because of the number of providers. It was really remarkable how community providers in health homes and hospitals were going out and getting the consents, because we couldn't go into the room unless we had consents. And from there, we started, the momentum of how we started serving people was shifting. The role in our MRT program, we needed to refer to health home. And that's when we started working with CDPHP. And CDPHP started contacting us about people that they were seeing, and we started contacting them, saying, can you please come and see Bob, you know, and we just really just started working together, and it was a very natural process. Then we had emergency room social workers calling us, and they would refer to us, but then they would also help us engage them. So if we could, if someone walked out or whatever it may be, we had a way of communicating with each other where we would, you know, we would get a call. Bob is in the emergency room, can you go over and see him? The police would call us, Bob is downtown, can you see him? CDPHP would call us, I'm meeting with my client, is there any way you can come and talk to them? So we really had to be on our feet and boots to the ground. Then that, obviously, it evolved to, we had psychiatric units contacting us, and also detox. And we would do regular rotations into soup kitchens and into shelters to see if there was anyone that wanted to talk to us. So when we started thinking about, when they started the social determinants of health, we couldn't really figure that out in the beginning, because when you think about, what is it that people need, we saw that they need housing, and we saw that they needed all of these things. It's, often you hear, well, once you house them, they're going to be okay. No, once you house them, a lot of things start happening, and you have to be able to, intervene, raise awareness, whatever we needed to do to keep them successfully housed. So when the first thing, what we needed to do was get income, because they were used to eating in the street, collecting cans, and we would take them to social services. And they also became a very important part of our team. We needed them so that we could get money to get them housed or to get them food. We would enroll them in Medicaid, anything that we could do. And then long term, we would look at other ways for them to sustain their income, because most of the time we could get that first part, and then when they started getting money, they started using, and they wouldn't go to treatment, and they would be sanctioned. So we always really needed to look at a backup plan. Housing, housing for us, we needed to make sure we had the right landlords that would work with us. Transportation. So with transportation, it's really great that we have circulation, but for our case managers, they needed to understand that part of our intervention was that transportation, because it gave us the opportunity to build relationships with people and help advocate for them when they're going to the doctor. Another piece, because most of who we served were actively using, we would have them come to our house. We're located in Albany. We have a little brownstone house, and they could come in there and shower and eat. So when they did need to go to DSS, they were feeling better and could communicate better, much better. And so it's really, and safety. So when we're talking about safety, we mean it in terms of some have domestic violence in the circle of where they sleep. So there are some places where they sleep, and you have to make sure it's a safe place in terms of that community of people who are maybe living in an abandoned building or on heating grades are not going to hurt them because of some of their behaviors. So that's really how our safety plan was going. And again, in order for us to address and to meet the social determinants of health, we could not do it alone. If we needed someone, if we needed to access something quickly, and we would rely on our team to do that, which was really, and it is, the City of Albany. They have been awesome with our project. So our case managers, we do have 3 FTE case managers. They would put it on here. Our staff are trained in a couple of evidence-based models, but one of them is SOAR, and that's specifically for individuals who are homeless, and you do a lot of work from the street. The trick about SOAR, if they're actively using or drinking, you have to prove that if you remove that, they would still be eligible for SSDI or SSI. And that was really hard when you tried to navigate that system, and only to find out they have to go into a treatment program first. So we're able to work that out in the community because we know it's co-occurring, and how do we tease that out? And we rely on, our clinical people in the City of Albany, Albany County Mental Health, CDPHP, to make a medical summary that supports their disability and doesn't focus so much on that they're living on the street. So health and healthcare, I mean, how do we address that? Again, we're very connected to our community. Albany County Mental Health, they give us access to their clinic so we can do a walk-in. With CDPHP, they will send a clinician with us, they will send a nurse with us, because what we find, you know, if we have anyone that can have in-house care for wound care, whatever, we often have to go with them because, you know, they can be pretty tricky when they have a lot of people in your apartment, and, you know, for safety and again, it's the connection and the relationship that they have with our case management staff. Again, I'm writing Albany County Mental Health because they really pushed us up. CDPHP pushed us up with the connection of getting the health care to people quickly, getting those referrals and really brainstorming on how we could make this happen. So when we look at role clarification, it was very clear what we could not do, and it was very clear what we needed from them, and that's what really made us successful in moving forward. So other things that we do, one of the things that we see with our homeless programs, it's really lack of connection. You can give them everything that they want, that you think they want or that they identify, but they really need to have meaningful connections with community, a social club. So if you're trying to not use and all your friends use, or that creates some, you know, barriers for them. You know, they're loyal to who they slept in the park with. They're loyal to where they're often victimized. That doesn't go away. So we really have to look at replacing that with meaningful activities. And when we went in, we're like, well, they're going to go for treatment and they're going to do this, and that wasn't our role. And we're like, well, why isn't this working? Well, one is they weren't ready to do that. But when we started talking to them, providing activities where they could get together, they started connecting, and they had a very positive outlook on what their future was, you know. So we continue to do annual summer cookouts, and when we do our cookouts, we're invited, the police cook for us. The first round, they were like, no way, and you know, especially if you had a warrant, you were out of there. But we really started working and saying, it's not about that, you know, it's really about getting to know these guys. And we would have care coordinators, CDPHP, everyone, Albany County Mental Health, they would all come down, and it wasn't an opportunity to get them signed up for something. It was to spend time with them and get to know them, so if they see you in your building, they can connect the face to someone that was a pretty nice person when they met them in the park. Thanksgiving, we make sure people are connected, and then, you know, we make sure they have warm clothing. We also have them participate in panels. So we've had a couple of panels that were really interesting and pretty funny in what they felt they needed. So our topic was, why do you go to the ER? Because we just have a strong emergency room presence with our clients. And their response was, they're taken care of, that people treat them nice, that they get food, and they're able to rest in a safe place. So it's really about making that shift into the community. What can the community do to create this level of comfort for people who have really only known danger? So neighborhood, you know, again, we have some things we do. So getting back to the social determinants of health, you know, you have to make sure, as the CBO, you have the resources you need to make that happen. So we reached out to supermarkets, And they started giving us food. So now our house has food that, you know, they can come by and they have access to food. If they spent all their food stamps, it's not fine, but we're going to wait for another opportunity to really work with people on that. We're just, you know, we're not constantly handing out, but we are, you know, we do meet the immediate need, and then from there, we start exploring what options are available for them. Albany Police. So Albany Police, it's interesting because when we first talked to them about this project, they were like, you're right. Now they're so engaged with us. They will help do wellness checks. If we can't find anyone, they'll, you know, if they see them, they're engaging them. They're not saying, oh, wait here until Louisa comes. They're like, hey, how are you doing? Where you been? And until, oh, can we call Louisa, we call Kristen to come and, and help you out. And that has really been very effective. And I think the other is they have, they look through a different lens now. It's not about, so if they're caught shoplifting, instead of arresting them, they're diverting them to us. And we're also a part of LEAD, which is an evidence-based practice for law enforcement assisted diversion. So we sit at their table as well, and we will get referrals, but when we're getting referrals, we're referring to CDPHP, we share the table with PSCC, and any other community providers that are involved with that individual, including ER social workers and nurses who do attend the PSCC. We meet as needed with CDPHP to talk about their clients, and then monthly we go through the whole roster of who we're serving under this new initiative that we have.
Louisa, can I just add one thing that I was thinking of? When we talked about the nutritionists that we have on our team and certified diabetes educator, a lot of people who have mental health issues can have diabetes because of some reaction to the medication. And so it's important to help them with their diet, and it's very challenging when they're using either food stamps or nothing or a pantry. So we've had our nutritionist has gone with Louisa's team, gone to the food pantries and said, here's the kinds of things that are going to make you feel better when you eat them. And here's what you can use your SNAP benefit for. So that's the kind of collaboration we do to try to get people to where they need to be, because they can't walk into the pantry and advocate for themselves for low carbohydrate foods when there's a plethora of carbohydrate foods available. So it's kind of how we work together as an example.
Exactly, that's great. It's using a community, it's using our partners, outcomes. And, just to touch on neighborhood and environment, it's really helping who we serve to be a part of their community, that it's not the community just pulling them out of ruts. They're active participants. They, it's important what they say. It's, and they have a voice, and we support their voice. So when we look at our host outcomes with CDPHP, so we have 63 CDPH members, and so we're currently serving 36 individuals in 3 counties, Albany, Columbia, and Rensselaer County. So out of that group, 63 of them were either enrolled in CDPHP, or we worked with enrolling them in a health home and managed care and CDPHP coming with us. From that, we just see immediate decreases in ER utilization. I think any hospital in Albany will tell you that. Once we get people housed, they may still have all of their baggage with them, but they're not using the ER in ways that were just high cost and unnecessary. We kind of made those connections in the community. So 23 of the individuals that we've served have moved on. So when we're talking about moving on, whenever we have any admissions, you're looking at what are potential discharges, you know. Some, 23 of them actually went into, 23 moved on, 14 of them accessed permanent supportive housing vouchers. One, interesting, we were housing them, and then they qualified for brain injury waivers, but it took a long time to really get that they had brain injuries, because up front they just look like they're using, they're non-engaging, but as they grew, we saw significant brain injury, and they were appropriately housed in either scattered site or project-based. Two, accessed a higher level of care. An interesting piece about that is this group, the two, have, they needed long-term care. You know, independent living, even with all the wraparound services, it's what they actually wanted. They felt safer once they were in there. Don't get me wrong, we had some that we brought all the way to Buffalo and they escaped and came back, found their way back to Albany, but that was okay. We just reevaluated where they were and what would our next move be in moving forward. And, you know, as in any program, we had a loss. You know, it's, you know, I think that's the hardest for staff when you look at the greatest income you could, the greatest outcomes you could possibly have, and then you have loss, because our goal is to never have that. So our outcomes have been very strong.
Can I just add one thing,
Sure.
if you don't mind? So from a health plan, we have the data in terms of the cost. And so for the three of us sitting here, the quality of care of the individuals' lives is much more important to us, but cost does have to matter. And so one of the individuals on this list in 6 months had 46 hospitalizations. And on average, a hospitalization is $8,000. So if anybody can do the math in their head pretty quickly, it can really, really be costly. And those admissions were not quality of health for that person. So it's, you know, it's staggering. And then once housed, there were no admissions. So I think it's like really just an amazing way that you can, you know, make cost better as well as quality.
So I wanted to share a story about Doug. And he was, we met him with Project Host, and he was involved in CDPHP. He was actually involved in any provider that could potentially serve him in any way. When we met him, he was referred because he had 160 ER visits in a matter of months. He was always in the ER. He had active warrants. He was often arrested for petty larceny or what do you call that? When he's
Stealing chicken.
He was always stealing chicken and stuffing him in his pants, and or he would just rant and rave in the street. So he was being picked up for all kinds of things. He had over 50 arrests, and you know, they were kind of tired of Doug. So we started working with Doug, and you know, he was not, you know, he is not easy to engage. You know, he had the language barriers, and he just lived on the street. He slept on the street. He had warrants. So this was where we were able to work with Albany Police and say, don't pick him up. I mean, you're only going to pick him up and flip him back out. Let's just keep it moving. And we really aligned. At one time, he was arrested and brought into court, and we went in and represented him, not as lawyers, but as support. And the judge, released him back to us with more of monitoring than any kind of sentencing. He had no support, he had no friends, he had no family, and once we housed him, he reduced to 20 visits. And they were appropriate visits to the ER. So in the first picture, that's where we started engaging Doug. He was actually outside motor vehicle resting. And he wanted food, but the case manager in that picture is enrolling him in Medicaid to get him connected to Help Home. And he would just talk to us, but he wanted to lay down. We did house him. That's where we saw the immediate decrease. But the things that we had to do was help him cook because he couldn't. And, you know, we would find bad food. So our staff started, he lived down the street from where we were. We would make food or we would get pre-made food for him because that meant keeping him out of an emergency room because he was hungry. He would go in saying his stomach hurt him so bad, but he wanted food. So we wanted him to be safe, so we started, this was not a long-term intervention of feeding him every night. They were strategies to just keep him fed, and then we would work on other ways to meet those nutritional needs for him. The second picture, you know, he's in his apartment, and he's looking great. The swelling's down, he talks to people, and CDPHP adopted him for Christmas. So this is a picture of him at Christmas time getting his Christmas presents. And, you know, he was always so grateful. And he came from Liberia as a child and lived on the street, just an awful, awful life. He was also involved in PSCC. And he would always say, as bad as his days were, you know, I'm 100% grateful for what you do. And, you know, and this was a guy that wasn't very popular in Albany, and he just turned it all around. As he started getting better, we started seeing, he started, you know, having some health issues, and a lot of it was related to his traumatic brain injuries. He had been beaten on the street several times, and, you know, he was just no longer safe to be housed. We continued to serve him. CDPHP was going over there, we were going over there. He was always discussed at PSCC, Albany County Mental Health, just what are we doing to kind of just keep him grounded until another opportunity opened up for him. And the last picture, he is, you know, he's in a rehabilitation center right now. He loves it. You know, he's losing his memory. We still go bring him chicken because that's what he likes. And although he may not remember us so well, he takes his chicken and he says, I want to go home. And he goes back to the center, and he always, you know, 100% grateful. So Philip, I mean, this guy is a guy who you just can never, I mean, he really makes you value the work that you do, because this is someone that people have been stepping over for probably 15, 20 years. So that's my story of my mother.
So you can see from stories like Doug's at CDPHP, we were closely paying attention during this first few years of Project Host to some of the results that were being achieved and the awesome work that Louisa and her team were doing. And we were seeing huge results. And with my background working in homeless services, there was a number of clients who I recognized from working for years in the homeless field in Albany that had been kicking around on the street for years, and there had been so many attempts to get them housed over the years, and they just could not hang on to their housing and could not find that rhythm of stability because they didn't have that level of intensive support they needed. So to see some of those folks still housed today and have had very long periods of sobriety even in some instances, it amazes me. So kudos to Louisa and her team. So this relationship for us started out, when we partner with community-based organizations, there's really a continuum. So it can start more in like a sponsorship realm, and then it can become more of a service collaboration right up to a structured service agreement. So this one, I think we had always sponsored St. Catherine's activities, but that's not really where we found our rhythm. It was in working side by side with each other to create really positive outcomes. So we've had an interest at CDPHP in the issue of housing instability for quite a while. We really recognize that there's that bi-directional linkage between homelessness and health. We did a training a few years back in 2017, Housing is Healthcare, and hosted 3 sessions, and the goal of it was to provide our own care team staff and local care management entities, any provider offices that were interested in sending staff, an overview of the continuum of services for people who are homeless or at risk in the capital region. So we went through everything from emergency shelter to eviction prevention services to permanent supportive housing, rapid rehousing options, and provided them with tangible resource guides that they could leave with for a better understanding of how to access those services. And it was pretty well attended. It had almost 100 people. So we knew the interest was there. Our team certainly kind of ate all the information up and then actively started using it. We've been an active participant on several of the local continuums of care, primarily Albany and Rensselaer. Albany we started in 2013, and if anybody doesn't know what a continuum of care is, these are local work groups of different agencies that receive HUD funding, as well as other stakeholders in the community, so systems partners from healthcare, law enforcement, for example, the business community, and they come together usually on either a monthly or a quarterly basis to discuss the issue of homelessness in their community, to look at upcoming funding opportunities, and as a continuum, they're able to apply for funding from HUD that funds all the wonderful local permanent supportive housing options in our communities. So we're very active. We found that to be a great way to find awesome partners like St. Catherine's by being at the table for those discussions. It's a great way of getting involved. And if anyone here is not a member, if your organization is not a member of a local, we call them COCs, I encourage you to find out how to join. And CARES Inc. Is the kind of the administrative arm of support for most of the local COCs. So CARES is a great entity to reach out to if you're looking to get more involved in your own local COC. We began embedding members of our care team at local shelters, drop-in centers, free community meal programs, and we found that, again, to be such an effective way of engaging folks where they're at, starting with them wherever they're at, not just as a cliche, but literally. If they needed their eyeglasses replaced or they had a toothache that was bothering them, we'd start there. We didn't jump right in with, let's get you housed, let's get you, everything we want to do. And we really found that to be an effective way of working with folks. And then, of course, our strong referral relationships with housing entities. So as Louisa mentioned, we served as a referral source for project host cases. Once they got their MRT funding, they had to figure out how to find referrals of individuals with high ER utilization, as the MCO. Of course, we would have that information and could make those referrals. So again, quick realization of the impact on some of the most challenging to serve cases. And it was this co-management that really became very evident to us was kind of the secret sauce. So St. Catherine's really working to the best of their skill set around their housing case management. That intensive level of case management they can provide where they're literally, in some instances, maybe in a park, sitting next to someone who's been sleeping on a bench and working with that person right there, providing case management, helping them get their needs met. That was the kind of boots on the ground resources that we were really looking for. And then it's just been a constant tag team approach. So we're always working together to get our members' needs met. Trying to manage things proactively, but I think that the nature of the population, oftentimes crises arise, and so we work together to resolve and address them. So it all just really clicked for us, and it was kind of a no-brainer to look at how can we take the model of Project Host, make some kind of tweaks to it, make it work for both of our entities, and enter into a contracting relationship. So what that looked like is initially we spent some time going over the ABCs of contracting, and that's not because St. Catherine's didn't know anything about contracting. You have many, many other contracts with government entities. So it was more around CDPHP's flavor of contracting and recognizing, okay, this is our first time going through this process together. So we spent a lot of time going over, here's what the structure of the agreement is going to look like. Here's where you're going to want to get your attorney involved. And the one thing I'll mention on that is just kind of some general advice. You know, we work with so many organizations, and it's important that you really read and also have an attorney read every document that's being sent to you. That sounds so simple, right? But I tell you, I have organizations where I'll send over something like a non-disclosure agreement, and it's signed and returned to me in less than a minute. So I know that it hasn't been read or reviewed, and just a word of caution on that. You know, you should always know what you're signing. If you have an attorney on your board, make sure that their background and skill set is well suited to reviewing these types of agreements, is another bit of advice I'd give you. And if you're hiring an attorney, just make sure it's one that you really trust and one that's not trying to kind of rack up the billable hours by dragging out kind of that contract negotiation process. So we've seen that happen in a few instances too. And we know that community-based organizations have limited funding, so it's you know, there's better ways to utilize your funding, in my opinion. We made a very, very conscious effort to keep year one of this agreement simple. So this is not technically a value-based agreement yet. That's on our roadmap, but as our contracting strategy at CDPHP, we never start in year one with that approach. That doesn't work for us, that doesn't work for the community-based organization. So again, we always try to start with the most simple service and reimbursement structure as possible. Because neither of our organizations are looking to get into a cumbersome relationship with a difficult reimbursement model that would be more time to manage than it's worth. We weathered the not so fun details of contracting together. So I think with most contract discussions, sometimes you hit a bump, right? Or you hit a stopping point where both parties need to come to agreement on certain terms in the contract. I don't think we've ever had an instance where we weren't able to come to terms on a contract, speaking broadly, not for a contract. But you know, it's not all sunshine and flowers, right? So again, it's important to know, you know, at the end of the day, you're both in agreement on what you're trying to do, and just try to work together collaboratively with everyone involved to try to get through some of those bumps in the road in the contracting process. So what we came up with is what we feel was a really mutually agreeable, beneficial service and reimbursement model for this contract. So for year one, St. Kathryn's was tasked with housing placement and support services for 15 to 25 CDPHP Medicaid members. Why is it a range? I think anybody that is in this room that works in the housing field knows that you never know how many you're going to end up with. So what we opted to do was really a global budget that covered both FTE resources and then a leasing budget. And so based on how long somebody needed the assistance of this program, what was their length of stay in the program, if they cycled off on kind of more of a short-term length, that opened up capacity to take on more referrals. And similarly with the leasing portion of the budget. So that's why we really have it as a range. We included funding for a minimum of 6 rental subsidies. All 6 are currently being utilized. I can tell you that we've made 21 referrals to the program, with 17 actually being placed in the program. Other folks were incarcerated shortly after the referral was made, and other kind of unavoidable things like that. So with the 6 rental subsidies, it's based on a person's income. They don't pay any more than 30% of their income. And we kept it at a low number A because the subsidies are very expensive to operate for those of you that operate housing programs. And B, there is a lot of other housing funding assistance streams in the area that we serve for this contract, which is Albany, Rensselaer, Columbia, and Greene. There's rapid rehousing dollars. I don't know if folks are familiar with that HUD funding stream. But it's short-term rental assistance, usually for about 3 months, I believe. The level of case management, though, isn't quite going to meet the need for the typical referral. Then folks can get a rapid rehousing voucher that'll carry them through a few months, while St. Kathryn's looks for a more long-term option for that person, ideally permanent supportive housing. And as Louisa mentioned earlier, that's where we can be really helpful at the plan, is we can line up some of that documentation for disabling condition. We can handle some of those moving parts and get that done a lot quicker. The contract also included language that, we're really looking for a person-centered model with that emphasis on long-term housing solutions. So it's getting folks out of whatever situation they're currently living in that's harmful or dangerous. So whether it's a shelter, sleeping on the street, staying in an unsafe living situation with a relative or significant other, looking to get them out of that situation as soon as possible and get them into something else, even if it's temporary, until long-term housing options can be secured. And we definitely were purposeful in our contracting language to keep this a flexible model. Again, year one, we both agreed and valued the importance of having some flexibility.
So it's going to be back to me, and I'm just going to go through some of how we believe that the hardest thing for my clinical team, because clearly anyone who's homeless or at risk for being homeless, to them was a high-risk person and should be in the program. But as Kathy said, when we teed this off, it wasn't going to be a value-based contract immediately, but we wanted to have a cohort of people that we would look at, that we could have decent consistency, so we could look at the outcomes, look at the program, and build that sustainable model. So we kind of had to, that's why children are not in this model. We have adults, so we'll talk more about that, but that was the reason for that. So one of our things that we had to work with the staff is to see who would be a good referral. So one of the ways that we get people into the program, and CDPHP has embarked on what we call our hospital experience program. We're moving away from having people, clinical teams in the hospitals only focusing on utilization. We're focusing on meeting people at the bedside with clinical teams and identifying when they have social determinants and things that you can't see from just a record. You need to really meet with a person and understand that. So we're rounding at 3 of the larger hospitals, and we're seeing people in the emergency room as well as at the bedside. And if we identify that someone is at risk for homelessness or they are homeless, we are getting those referrals over immediately. And because of the way the program's structured, we don't have to follow the HUD-defined guidelines to the fullest. We can be a bit more flexible with that, which has been a really good part of the program. So that's one of the ways we do get the referrals. As Kathy said, we are out in community agencies, so we have people in community breakfast and in shelters in the area, and we identify people there and can get those referrals made. We also have that partnership with CARES, and we do get the Homeless Management Information System data, so we can look and see where people are being sheltered so that we can actually find people, and that's very helpful. Because your systems in a health plan don't always list a person as homeless. Once we know that information, we'll track that. But sometimes you have to be very much like a detective in determining, oh, well, that's a shelter's address, so therefore we know that they don't live in an apartment. So it's kind of getting a little bit creative in figuring that out. St. Catherine's, when they find people and they know they're CDPHP, they'll refer to us to refer to them, essentially, and kind of like get that partnership. And other CBOs are learning to do that as well. Some of our physicians, that isn't our largest referral base. We want that to be a larger referral base, but we are looking to educate them more on what we're doing. But some of our providers who have a very high Medicaid population and who have a lot of individuals who are homeless do know to make those referrals to us. Slide, Kathy. So what makes you eligible by the contract that we put in place? So it's single adults, 18 years and older. They have to reside in, as Louisa said, Albany, Columbia, Greene, and Rensselaer counties. That's their catchment area. This is where it gets a little bit more clinical in nature. So we want to identify people that have chronic conditions as well. And we want to look for people who have either medical or behavioral health conditions combined. That, we're not expecting that people be in treatment or fully sober at the time of going into the housing. That will be part of what we'll work on, is helping them to get into rehab. But we're not going to only look for housing that will allow people to get in that are not drinking or using substances. We had one gentleman in Project Host that we couldn't get him in a particular housing unit because you couldn't have alcohol addiction or actively using. So in this program, Louisa is able to be a bit more creative in that, and so we can get people into programming. And we'll work with people who are at risk for homelessness, maybe multiple evictions, and we know they're not going to be able to maintain where they're currently living. So trying to find something that's a little bit more flexible for them. The big caveat is people who have had a lot of hospital admissions and emergency room use. And that's for things that we can look at our data and see if it was an admission for something that was avoidable or could have happened in primary care or could have gone to an urgent care. Because we have that rich data, we can tell that. We certainly know if someone is in a trauma or a car accident, they belong in the emergency room, but we know there are other things that will be better served by going to a primary care provider. We look at these referrals and we have what we call our little kind of clinical team committee that works along with Louisa's team. And we review those together and we say if they're not really appropriate for this program or consideration, let's see what else we can provide for them and help them with. So we meet on a regular basis, and every single one of the cases that our teams identify or that comes in through an outside source, we immediately within the next business day review all the information we have to say, does this person fit into this category? And what we're hoping to do is take those outcomes that Kathy's built into the contract to say, we can run some data at the end and say, are we making a difference and can we continue to sustain and grow our program, essentially. So some guiding principles of what we think is our key to this program being successful. You've heard us say the word co-management multiple times, and it's really the hallmark of this because many times when a clinical organization is working with a community-based organization, there's a lot of back and forth, push and pull. Well, what do you do? What do I do? That didn't happen here. We were able to really define our roles. And we took some very good lessons learned from our interactions with the health homes, because the health homes have great resources, but they don't have clinical resources. And in many instances, we were able at CDPHP to work with our health homes, and that was a good plus. So this is what we felt was important with, say, Kathryn's as well, is to have that, sometimes we go together to an appointment. Sometimes we have you take the lead, but we make that very evident to the client that they know you've got a team here, and we're going to have the right person to go with you to an appointment or help you with that need. So that feet to the street piece was so important, and when I started to develop some of the feet to the street concepts in my case management program with the help of Kathy coming on board, my chief medical officer looked at me like I had 3 heads, we're going to do what? And now they want us to do it so much more because they are recognizing how important it is. One of the big pluses that we saw is we track our engagement rates in care management programs at CDPHP across all lines of business. We currently have a 78% engagement rate for Medicaid. So if we get a referral, 78% of those people will engage. We were at about 25% before we did feet to the street. So we know that it works, and if you can't engage with someone, you really can't do anything. It's just impossible. You've heard Louisa say we have to meet the person where they're at. That's absolutely essential. And for us, the clinical teams that I have are very impatient. They want it to happen now. And we know that individuals who've had struggles enough to make them be homeless, their needs are going to take. It's longitudinal. We cannot make it happen overnight, but we have to be patient and we have to find out what they need. My team has gone to more dental appointments and more eyeglass appointments because that broken stem in the eyeglass is what's making that person's day horrible, versus the fact that they have diabetes and they have to get into a rehab program. But once you kind of make that little plus for them, because trying to get an eye appointment for someone who's homeless is not an easy task. No one wants to take them. So if you can make that happen, you've got a friend for life. So that's what we're trying to do. And really a holistic plan for ongoing supports after they're housed, because as you heard Louisa say, housing is clearly the most important thing, but the loneliness that occurs when someone gets housed, they don't have the socialization that they got at a shelter, believe it or not. So trying to provide those kinds of supports, which Louisa's team does a great job at. I think that's on to you. That's back to you.
So some of the evidence-based practices that we use, let me start with critical time intervention. Critical time intervention was identified back in like the early 80s when they started discharging individuals from psychiatric centers with no plan, and they were going into the streets, and that's a big part of homelessness for a lot of who we serve. They had a history of being hospitalized, and then once discharged, they were just disconnected and ended up living on the street. It's a time-limited evidence-based practice. So how we implement it is our goal when we first meet someone is to talk about, how can we help you? Although we may have information about them, we want to know what they want and what they think. And from that, we develop the relationship. It's time-limited, so with Project Host and with CDPHP, the goal is to create areas of focus that they identify and help and support them in achieving it. Now, the struggles that I think everyone has is, we have all the answers, so we can't figure out why we just can't do it, and they tag along, and it just doesn't work. When we're meeting people, we're not going to talk to them about how they need treatment or they need to stop drinking. We're really just talking about how can we help you today. And every day is a new day. And if you don't like me today, I'll call Charlene and she can have someone go over and maybe they'll like
She
her.
makes me tell them they have to
Whatever we need to do, whoever the best person is at that time. And we don't give up. So there's no dropout. We keep engaging, and although we may not be engaging daily, they may say, get away from me, I never want to see you again. That's okay, we're going to leave them alone, but then we'll see them on the street or whatever and try to re-engage them. And then so then as we're focusing on areas of focus, there's 5 areas, and they're all what we want too, but they also identify how they want housing, how they want connection. And there are some strategies that we can develop with them, and they can help identify to achieve that. And as they're achieving the goals, they're measuring their own success. So we may be saying, yay, they're not in the ER, but they're saying, I can't believe I did that. That I didn't think I could go through with that. Or I'm going to try this. And sometimes their ideas are not very popular for anyone, but it's okay, you support it, and then, because failure is an option, right? It's how we all learn. So we're going to go back and say, okay, so now what do you think your next move, what do we need to do next? And they're empowered to make their own decisions. It's so easy to answer for them and plan for them, but if that connection isn't there, it's not going to happen. So critical time intervention is the foundation of our case management, and we meet weekly, and we, as a team, to talk about where people are at, what we are doing, and what are some strategies. And then if there is any clinical consultation that we need, we're reaching out to Albany County Mental Health, CDPHP, to make that happen. Housing first approach. So many people that we meet, they don't believe that they're entitled to housing. No, oh, I can't go there because I was drinking, or I have a felony, or, yeah, right, they just don't believe it. So with housing first, we're not really talking to them at all about their drinking and or drug or whatever it may be. It's where do you want to live? Where do you see yourself living? And we'll try to make that happen. It's not like we're housing everyone in Loudonville or somewhere, but where do you see yourself? And they want to stay by the park because they like to go visit the park. But that also gives us an opportunity to say, okay, we can find you a place by the park. Let's think about some pros and cons about that. But, if they come intoxicated, we just keep it moving until they are ready, until we get them housed. Motivational interviewing, it's just, we are very, our case managers, we have spent a lot of time in this skill set because if you want to meet people where they're at, you really need to keep the conversation in their ballpark. And and hear what they want, and you know, see, you know, and the best that we can do is maybe evoke some change talk or something, but that really builds the relationship. So if their best laid plan doesn't work, they're definitely more open to hearing about it because they're not feeling judged. They're not feeling like someone is deciding for them. And then they're open to exploring situations. So those are the 3 evidence-based practices that we use in our QA department. We monitor the fidelity of that, of each practice as well, that we believe, well, we know. Definitely work, you know, our engagement with who we serve is very, very high because of the models that we use.
Great. So I'm going to talk, so after you heard Louisa talk about Doug, and that was our project host, but then once we started this housing subsidy program, this is an individual that we've been working with. So he was diagnosed with schizophrenia many years ago, middle-aged gentleman, poorly controlled diabetes, which does happen and is common. He also had asthma. So he was using cocaine and alcohol regularly, which everything was just complicating his situation, and it resulted in him becoming homeless. The only health care he was receiving was happening in the emergency room and would often result in going to an inpatient stay because he had so many issues medically going on. So he had 11 ER visits and 3 admissions in 2019, and as we said, that can be very costly, and also he wasn't getting linked to any kind of primary care. In fact, in the 22 months prior to us getting involved with him, he spent $98,000, and all of that was just on care that was not improving his health in the least. It was just stabilizing him through an emergency room. So John he was identified by one of our CDPHP heart case managers who was out visiting a homeless shelter. She met him and began working with him, and then made a referral to Louisa's team for one of our housing spots and supports. So while he was awaiting housing, they got involved, and while he was awaiting housing, he was open to considering going into rehab. So the housing process took a little bit of time, but not a tremendous amount. And he actually was housed through St. Kathryn's in August 2019, and he had begun going into rehab then. So now he's currently housed, stably housed. He's checking his own blood sugars. He was linked by our case manager, along with the support of Louisa's team, for transportation and things of that nature. He sees his primary regularly, his blood sugars are in control, he's taking all of his medications, and he hasn't had any emergency room or admission since he was housed. We're seeing he's still incurring costs, not anywhere near what he was, because he's getting the appropriate care. So the care he's receiving is he's taking all of his antipsychotic meds, he's taking all of his diabetes and asthma meds. So we're seeing a shift into more pharmacology versus like unnecessary emergency room. So what's going to stay in place, because we've learned through the Project Host arena, is that we want to keep those wraparound supports. So we feel like that's not, a great story and we'll just walk away. Louisa's team and our team will stay involved, because relapse is very common, and if that would ever happen, we want to be there to be a safety net to help. And we want to make sure he stays involved with all of his, psychiatry providers as well as his medical providers. So both teams will stay in touch and involved with that case.
So when it comes to project measurement, so again, keeping in mind we are still inside of year 1. We signed the contract late last December. There was a hiring period, so really started taking referrals probably February, early March. We did include in the contract some performance targets. They were not tied to payment in year 1. So the performance targets were mainly around the housing stability aspect, and then the social determinant of health screening pre and post. So we included those on this slide for you to see. Again, trying to keep it as simple as possible in year 1. So what are we at CDPHP going to be measuring for this project? So of course, a lot of emphasis is placed on total cost of care, but I want to emphasize it's not all about just total cost of care. If that were the case, we wouldn't have a triple aim, or we call it the quadruple aim. But there's other things that are just as important that we're going to be watching and monitoring with this project. So obviously ER and inpatient utilization, we would love to see appropriate primary and specialty care utilization. Medication adherence, as Charlene mentioned, will be one of those things that hopefully drives up the cost in a good way initially from what it was before. And then you'll see some things on this list that we can't get from claims, right? So housing retention and stability, criminal justice involvement, social supports. So those are data points that Louisa and her team are going to be providing to us for each case so that it can be factored into our analysis. And I mentioned the social determinants of health, pre and post screen at the 6 month, every 6 months. And of course, HEDIS gap closure is something that is near and dear to every health plan. So we're going to be looking at what efforts Louisa's team was able to make in getting some of the preventive care gaps closed. On our gap list for things like mammograms, colorectal cancer screening, a significant portion are heart members that have significant mental health, substance use disorders, a lot going on in their lives, and their preventive care is the last thing they're thinking about. So we do see a lot of health disparities there. So to me, I'm glad we were able to include that as a focus in this project.
Kathy, can I just add one thing on the medication piece? So one of the things that our psychiatrists in our health plan is very focused on is us trying to facilitate more long-acting injectable medications for people with that need antipsychotic medications for the adherence piece. But many of the providers are hesitant to do that if they can't get there consistently. So we're trying to do all those wraparound supports to support that, because we've had some real successes with people, both with alcohol and substance use disorder, getting on long-actings for Vivitrol and also for antipsychotics. So we're working towards that. And I think this is going to help this because we can really encourage a provider to feel comfortable that we've got a wraparound supports to get that person there if they initially. So I give Dr. Fernandez her, I give one from her.
So we're going to be measuring some different things longitudinally, but of course total cost of care will be one of them. We'll be looking to calculate hopefully savings on a PM basis. And as I mentioned, other areas of impact will be monitored to really have more of a holistic analysis of the impact of this project. Instead of just looking at, the traditional ROI, looking at VOI, and I don't mean value on investment, but value of impact. So what really is the full impact of this project, and looking at all these different data points, hoping that they weave together a narrative that I hope shows the same great results that we saw with Project Host, and maybe even higher than that. So we're very excited to see what this brings. There was early conversations, I'll be candid, let's start measuring at 6 months, let's start measuring even at a year. I mean, we're going to see costs go up initially, so the total cost of care equation really needs to get looked at over time, and inside of a year, I think it's a waste of our time to be looking at it, to be honest. It's going to take a while with folks that have some pretty entrenched issues and some issues with their health that are pretty far progressed, so we need to help get those under control, and then as things start to stabilize, we hope that total cost of care comes down. So just kind of in closing, some lessons learned for effective collaboration. I can't emphasize this first one enough. So our philosophy on service and mission are so closely aligned with St. Katharine's. Our CEO, Dr. Bennett, talks a lot about wanting to do the right thing by our members, and especially our members who are often marginalized and don't have access to the same services and resources as other segments of the population. So again, I feel like our missions are so closely aligned in that. And then our philosophy on service. If you've heard anything from Louisa and Charlene, I hope what resonated with you, they really both have like a whatever it takes approach. So they're going to wrap services around people, meet them where they're at, and it's whatever it takes to help that person reach a more stable place in their life. And definitely a respect for the skill sets that each other brings, and that role definition is key. Trust takes time with any new relationship. I'm sure everybody's learned that in life, right? But it's no different when two organizations are working together. And it really is action that kind of proves out that trust over time. And this wasn't a partnership that formed overnight. We had a couple years of just this more informal collaboration working alongside each other. Again, keep it simple. Resist the urge to overcomplicate contracts. And regular communication. Our teams are in touch all the time. That's also what's made this very successful. and just a commitment to really be in it to win it. We really believe that this program will be successful, and that takes a long-term commitment to make that happen. So, nice little quote here from Henry Ford: coming together is beginning, staying together is progress, and working together is success. And I think that definitely holds true for this partnership. So we provide you with our project contacts on this slide for anybody that needs to reach out to us. We do a lot of contracting directly with community-based organizations. We're also going to be working with the IPA as well. And we have had contracts in place with community-based organizations since 2013. So we've been doing this for a while. We've had some value-based arrangements in place with community-based organizations since 2014. So we're always looking for new opportunities and new partners.